Section 4. Hope you all are all doing well. I know some of you are off to weekend intensive this weekend, probably the last group to go, if you will, and so hopefully you're enjoying those. And for those of you who are at home, hope you're having a great weekend. Had a good week this week with lots of good discussion, despite the fact that many of you mentioned that you really don't treat this in a lot of instances, but definitely found the information enlightening and perhaps applicable in many different ways, as opposed to just in treating the hand and wrist, which some of you apparently don't get access to, which again I think is sad, but we'll kind of address that as we go. So let's get into the wrap up for the week. Looking at the Coptiera article, the sliding techniques were, in that article, I think the big take home there was that the sliding techniques were associated with a greater excursion. Elbow movements represented the largest excursion at that joint, if you will, and discussed at length in the articles the mechanical behavior of the nerve between the two joints. Right, so when sliding techniques can happen between the two joints, that's when you're going to get the most movement. And the question then becomes, do we slide or do we tension, right? And for some of you, I showed you a couple of articles about that, and does that really matter, and is it important? Because I shared with some people a Cleveland article that looked at tensioning in the sciatic nerve of the lumbar spine, and there's some debate about, first, I think one of the things that we can say is that for the most part, sliders can be a lot more comfortable and a lot easier to perform for patients, and that maybe they're more for the acute patient because you can be more aggressive sometimes with stiffer nerves, and maybe it has to do with what's happening within the nerve, that interneurial space, with sliding versus tensioning, and that maybe the chronic patient has more tolerance to the tensioning, but maybe they're both good for chronic pain, and that tensioning is really sliding is really just the way to go in all cases. But yet, like I said, I shared that Cleveland article, which makes people makes you think a little bit that maybe tensioning perhaps shouldn't be demonized, I guess, as much as it is. But anyways, the Coptier article certainly demonstrated that sliding was a great way to get excursion. And I would, I have this article or these pictures brought up, kind of as as example. Hopefully you paid notice, because I will say that I do use this diagram off to the right quite often, if I'm looking for a good median nerve slider, and I love the variety in which the JOSPT article breaks it down for different spots, and how some people handle this differently, but it's not uncommon for me to even give this out as a handout. So just keep it in mind and keep it handy, and appreciate the variability within this one particular nerve gliding technique. So the CPR of Weiner is strong for the CTS. I know that this isn't a cervical thoracic course, but hopefully you all got a chance to check out. I brought it up and I posted in one of the Dropbox sections the CPR that Weiner has for cervical radiculopathy, and helping us do a better job of kind of ruling in and ruling out peripheral versus central problems. And then this CPR that Weiner did, and they were all kind of tied together on CTS, looking at the wrist ratio index, which I think is an interesting test, because not a lot of people are familiar with this, and so it's interesting how it found its way into the CPR. It's not a incredibly tedious thing to measure, but I do find it interesting. For me, the shaking of the hands, man, that is, like, I just find that to be way common in the people that I see with CTS, and I don't see a ton, but I see them more at one clinic that I treat at than at Target, more at the corporate clinic, because there are no OTs there, so I'm not competing with them for patients, and so, but that shaking of the hands always comes up, I feel like, and so I even feel like it's more than 0.81, but that's just my own personal bias. So be mindful of the rule. I think I talked about it with a couple of different people this week that it hasn't been validated. Get that, but again, clinical prediction rules are not meant to be gospel. They're used as a guide, as a reasoning, something to help you kind of hone your clinical decision making. So just be mindful of it. Right? Again, it's not gospel, but be mindful of it. The Talakabi article, where we were looking at the nerve mobilizations versus carpal bone mobilizations, Pain relief was the only thing to show statistically significant improvement. No difference between carpal bone mobilizations and nerve mobilizations. I pose this to a number of people. What is the treatment effect here? Is it that we're, mobilizing the wrist and it's moving more freely and helping that nerve pass through the carpal tunnel space, or is it that the we're mobilizing the nerve, getting that peroneal space to move better, or are we desensitizing the nerve, whether we do that with carpal bone mobilizations or with nerve glides? And much like any other joint mobilization, I would argue that we're probably providing some form of neurophysiologic treatment into that space. And whether we do it through joint mobilization or we do it through nerve mobilization, the effect ultimately is the same thing. And I guess what it tells you is that you have options, right? You have options in how you approach a patient, and I would take and apply that directly to other areas of the body as well, right? Knowing that our manual therapy techniques have a dampening down or a desensitization of the nervous system. Week 6 discussion. So there again, the big topic, or a lot of comments about OTs treating hands, wrists, elbows, and shoulders. Okay, so my take is that they continue to have kind of encroach on that area, and we don't push back on that, and I'm not quite sure why. Is it that we're all just trying to get along? Is it that we're trying to divide up areas so that I'm not really even sure. How have they kind of creeped in? In my opinion, it seems to me like there's a little bit more demand for PTs, and so because of that, we get just kind of siloed off into a certain section, so that the OTs can take those patients that maybe we're trying to treat the rest of these other group, but we can't quite get to these, but we know the OTs can treat them, and in doing so, we've kind of given up some areas, and I do question that, and I think everybody should. Who is the best to be treating these? When we think from a regional interdependent standpoint, and we know the effects of cervical manipulations on elbow pain, we know thoracic manipulations on elbow pain, we know that certain cervical side glides on elbow and wrist, median nerve mobilizations, they're not doing that stuff, and are we not giving them the best? Tensioners versus sliders. I had a Butler article that I gave out to some people that kind of looked at some of the mechanics of what was happening, and just appreciate that tensioners are maybe have their place. Sliders certainly do, but are we really moving the nerve? Is that really what's important, that the nerve is adhered into the tissue, or that we're providing a neurophysiologic or desensitization? Now, the jury's still out on that, I think, and you can certainly take sides, and that's why we stay tuned for what more information comes around, but do pay attention to that. And then screening out peripheral nerves versus central nerve injuries, knowing the cervical myelopathies, cervical radiculopathies, as compared to more nerve entrapments from the presentations that we got this week. So being keenly aware of those, and not ruling those, or not forgetting about those, so that you can rule them out. Okay, lastly, as we wrap this up, week 6 behind, week 7, we're gonna take a deeper dive into regional interdependence. We're gonna go from cervical spine down to arm, and really look at the effects. Got a couple more articles we're gonna dig into on that, and as well as some presentations. The subjective portion is due, but you don't need to hand it in, and I apologize if I did not make that clear. You're going to be using that to help you do your objective information. For those who did share that with me, thank you. You're just obviously you're a step ahead of the game, so it's not a big deal. I'll be including the objective portion on Monday for you guys to get that feedback. If you can, there's a section here for the weekend intensive feedbacks. If you could all fill those out, just to let us know what you thought of the weekend intensives. I'll be sending out also a survey in regards to the group projects, and you just answer for your members of your group, just to give me a sense of how everybody did. Was everybody fully participating? If everybody was, outstanding, then everybody gets a great grade. If everybody does a great job, and if they don't, and sometimes that happens, I just want to be able to give everybody appropriate credit. Stay sharp in the final weeks. It's week 7. We've got 2 more weeks left. Don't start to fade off, because this next week I think is really a good week, and really kind of wraps up what we've been doing. And then we get to talk about sports week 8. But otherwise, if there are any questions, again, drop me a line. I've been able to communicate with with people if there are problems, and hopefully solve those problems relatively quickly. Enjoy the rest of your weekend, and look forward to hearing about, again, your opinions on regional interdependence and seeing your work in the group projects. Take good care, all.